Thank you. Welcome to the afternoon sessions. This is one area which we wanted to bring it to you because this is very disappointing. Can you get the screen on? The very disappointing disease, aortic aneurysms and dissections. Once you diagnose, many a time the diagnosis is late. Once you diagnose, there is a tendency among physicians to think that this disease is untreatable. We just say that, okay, your fate is not good. In fact, honestly speaking, many reputed cardiologists share the same sentiment, but it is not the truth anymore. I will just show only the issues which will tell you, will convince you that the therapies for this disease are not that difficult. We have a variety of aortic syndromes. This type of aortic aneurysms, when you find, in fact, very sad that we are diagnosing this aneurysm so late in our patients. This man underwent a CABG surgery in a reputed center, but at 3 years after the surgery, he comes with severe abdominal pain, impending rupture actually. So you can see that this is not the real aneurysm size. Whenever we do CT autogram, whatever is seen is a lumen. Outside that, the aneurysm will have a lot of big aneurysm with a lot of clot. This is a reconstruction only for the lumen. So this is a late diagnosis. You have to be very careful, diagnose early, because above 5 centimeters, the chance of rupture and rupture of an aortic aneurysm is a catastrophe. So of course, when you see these aneurysms, you don't have to worry at all. Just send for a good CT, spiral CT autography, because many of these cases can be treated. Once upon a time surgery, very risky surgery, complex surgery. In fact, this technology of endovascular stent graft, a covered stent graft, was actually propounded and developed by Parodi, who is a great surgeon himself, because surgical procedures are very, very tiring and not so fruitful with a lot of complications. And in fact, even in most of the centers, like our center is a reputed center for all varieties of aortic disease treatments, one of the team members along with me will be a vascular surgeon. He will be a part of the team because they don't like to do surgeries in these patients. They want endovascular procedures. So a covered stent graft, if the aneurysm is there, it's just a stent graft with a cover, PTFE or material. The moment you release, or a polyethylene, you just release the stent, it just opens, self-expandable. And then the aneurysm is excluded. Whatever aneurysm is there, it gets thrombosed off. The complications are extremely less, quite a simple procedure. Only thing is you should know which cases this simple procedure can be done. When you want to land it in this aneurysm, you need a good neck here, at least 15 millimeter. You should have good landing zones distally, and you should have certain criteria for the devices to sit in. A variety of diseases, issues are involved here. A lot of companies have produced this type of grafts, and we have used all of them in appropriate cases. The problems happen when this neck is little. How do you land the stent? It may drop down. So we call it as the hostile necks. Nowadays, we are confident of doing even 10 millimeters neck. And in fact, we have done last week 8 millimeters neck also with special techniques. So this patient, very simple, just put a stent, this classic bifurcated stent graft, you call it. They don't take much time. We can do percutaneous totally, but usually the vascular surgeon will open up the groin. We send the device through the groin, and then they close it off very neatly with a suture. So excellent results. We keep a surveillance to make sure that they don't come back with the problem. But many aneurysms, in fact, honestly telling you, 12 years back or even 14 years back, many of these aneurysms we used to turn down and say, no, we cannot do intervention because the neck is not good up, or low down, the iliac landing zone is not good, or there are some other issues involved. Branches are coming, the neck is involving, the aneurysm is involving the renal arteries, or SMA, or EIM, or celiac axis. All these are not ideal, but once upon a time. Now we have technologies and techniques to overcome all of these types of issues involved here. You can see that sometimes aneurysms involve thoracic as well as abdominal aortic. How do you tackle that? So many branches are coming. When you cover up with a covered stent, what is going to happen to the patient? Do they develop visceral ischemia? Do they develop paraparesis? All these issues I'll show you just is a journey of just showing you what all can be there. So this is a double aneurysms, thoracic, abdominal aortic, multiple. You have to cover up all these branches. Already one kidney vessel is gone. So what we can do is, one option is, you can do several things with these visceral and renal arteries. You can put a chimney. It means you can put a stent covering the renal arteries, but then here we can put one covered stent from each renal artery coming up here. So the kidneys will get blood flow from side of the stent. This is called chimney stents, chimney EUR. Or you can put holes can be made in that stent graft. You can send the CT scan to the company. They will make branches or holes, fenestrations we call it. That graft will come back to you within 3 weeks, and we can do the procedure. Through the device, we can put covered stents covering up. So branch or bifurcated. Or hybrid. Hybrid means the surgeon will take a graft from the common iliac and supply all these 3 branches. Whenever the surgeon bypasses to one of these visceral vessels, he will also tie the vessel so that there is no endo leak. So in this case, what we did was the surgeon did you can see that from the iliac artery, a graft is going up and filling the celiac, SMA, and the right renal artery. So once he does that, our job is easy. We go and just deploy these stent grafts. So already this is called hybrid procedures. They do half of the procedure in the surgical theater, they shift it to us, and we complete the procedure in the cath lab. Extensive, challenging landing zone. Sometimes landing zone, here also you can't cover the subclavian above. So, and below you can't cover the celiac. So there also we can do different types of techniques there. Sometimes iliac artery also has got aneurysm, not only abdominal aorta. Then what do you do? Again, the same problem. Distally, like this patient has iliac artery aneurysm also. So we can do several techniques there. There is something called EVAR plus. We are putting one graft only into one limb, one leg. And for other leg, we close up that artery with something called a plugging, and then the surgeon completes it by bypass. Leaking aneurysms, they're notorious, but once upon a time, 100% mortality. Surgical mortalities were almost 70% to 80%. Now we are able to save these patients very easily. There are some techniques we use called plugging. Whenever we close these aneurysms, if the vessel is there by the side and if you don't close that, the leak will be there from that vessel in a retrograde way and continue to expand the aneurysm. Endo leaks, they are technically, of course, we are not going to that. This is the AUI device, and we have closed that artery here with a plug. Huge thrombus loads, iliac aneurysms, you can see the aneurysms which are there. We use special techniques like pluggings. You can see here, sometimes we'll have to coil these arteries. Here we are closing the internal iliac artery deliberately because otherwise it will continue to leak into the aneurysm in a retrograde way. One iliac artery you close, it doesn't matter internal iliac because from the contralateral internal iliac it will fill. So one internal iliac you can close provided the other one is good. So here we coil embolize and then we go ahead and do the classical bifurcated graft covering up the iliac. So iliac aneurysm also is excluded here. Aortic aneurysm is sealed off. Renal arteries are involved. As I said, once upon a time, you could not land a device. Renal arteries are involved. Aneurysm is bad. You have to cover from here. So how do you do that? So here we are doing something called chimney. One renal covered stent is coming from the left brachial, another from the right brachial, and the device from the leg. So we are deploying that. So all the three, the main aortic stent graft, renal stent, we do special techniques to make sure there's no endo leak. So bilateral renal chimney stent. Chimney stents can be done even for pararenal accessory arteries also. So the technology has evolved so much that our techniques parallelly have converted into high procedural and patient success. The finer nuances are not needed now. Pararenal chimneys, you can see those techniques. We have done quite a number of renal chimney EVARs. Pan-visceral aneurysms, fenestrated EVAR. This is a company-guided FEVAR. You send the anatomy, the CTs to the company. They make the device in Australia, send back the device custom-made for that particular patient with special markers to identify where the arteries are coming from. So in the lab, we go deploy. These are all a little bit of complex procedures, but it's all possible. This is a Cook graft we are using in this patient. And this was the 3-year follow-up. Excellent. Acute aortic syndrome, again, don't forget, any pain here or in the back is not always pulmonary embolism or ACS. You should never miss acute aortic syndrome. Dissection is a notorious disease. Type A dissection involving ascending aorta, very much need for early surgical repair. Aortic ascending aorta, surgical repair. All other types, we can intervene. Interventionist has a big role, we can put grafts. So if this is involved, surgeon has to tackle that. Many a time in extensive dissection, surgeon does the surgery here and it does something called elephant trunk. He leaves it. Later on follow-up, we'll complete the procedure of the rest of the thing. Pseudoaneurysms are a very notorious thing. Patients come with symptoms like some chest pain. Here you can see a small pseudoaneurysm. It looks small here, but in the CT, if you see, it's a huge pseudoaneurysm compressing the esophagus. It goes for a gastroenterologist, dysphagia. He finds esophageal compression, and you find a thrombosed pseudoaneurysm. Very simple. Just go and put a stent graft. These are all cases which are so easy to do. The procedure would take probably 10 minutes. The surgeon will take about 10 minutes to open up the groin. The procedure can be done even with total PUR, total percutaneous procedure as well. Extensive aneurysms here, there, pseudoaneurysms, aortic ulcers, all can be done right from the subclavian. We make sure that the landing zone, you don't compromise the vessel. If the subclavian is there, you have to deploy the stent graft exactly there, because if you cover up the subclavian, it is a catastrophe. Of course, there are some bailout procedures we have in hand, but we always try to avoid those procedures. One important thing, like acute coronary syndrome, primary angioplasty, for aorta also there are some disorders like aortic disruption. These are two classical cases from our highway from Chennai to Nellore. Road traffic accident, car accidents, aortic disruptions. Both these patients, youngsters, 39, 40, the aorta is totally torn inside the isthmus. As you know, the aorta is fixed in the descending part. Arch will have some mobility, that there it gets torn, and then entire disruption of the thing is there. Diagnosis is very easy. Patient will be very critical and sick. In the middle of the night, like a primary angioplasty, we do primary stent grafting, and they can easily be saved. Sometimes aortic injury, pseudoaneurysm can be so slow and insidious in onset, like this gentleman who comes with hemoptysis after some road accident 20 years back. And if you see that pseudoaneurysm is calcified, you can see the aorta is calcified, pseudoaneurysm, of course, we can tackle even such cases that pseudoaneurysm can be excluded. Some are very memorable because one of my earliest stent graft, probably probably it was about 20 plus years ago. My classmate, who is an orthopedician, unfortunately had a road traffic accident, multiple fractures. He was on ventilator in Hyderabad. He recovered after all this, but then they found that he had an increasing, gradually worsening pseudoaneurysm, which was causing trouble at that point of time. 2000, I think there are very few people in the country doing these complex procedures, so we had to put in a stent graft and save him. He's doing extremely well. The durability of these procedures is very, very good, the current generation ones. And this, of course, pseudoaneurysms are very, very easy to treat. Just go and deploy the device. It doesn't take more than 10 minutes. He does extremely well. I'm very happy. This was, I think, now 20 years now. Mycotic aneurysms can be there, fungal aneurysms. There's usually we like to avoid endografts. Infection, avoid endograft. But when you're forced and the patient is dying, sometimes we go in and save the patient. Sometimes some places, if the technology or the technique is not good or the indication was not good, here in this patient, the stent was put somewhere, but it continues to leak. He comes over. So this is the problem. Whatever stent they have put, it is leaking like mad here. So we had to go and repair that job. Luckily, he didn't collapse. We put in one more stent and saved the patient. So this is it. Giant aneurysms, this was probably 100 plus in an 80-year-old, very huge giant aneurysm. We can save these patients as well. So there's a variety of disorders. I think I should end with this last slide. If you see this patient, how late they come. This is not the heart shadow. This is an aneurysm. He's come from Africa all the way because they said they cannot touch him. You see the vertebrae are all eaten up. He's got paraparesis, but he wants to live all the way airlifted. This is not the cardiac shadow, this is aneurysm. And this type of cases also can be saved. You can see that. Such a sad thing that in the current era, if you are missing aortic aneurysms to go on to develop to such an extent, that means somewhere the awareness is not there among the general medical population. In a nutshell, aortic pathologies. I didn't consider on the dissection part. It is even more a different entity altogether. They come in all sizes and shapes. Early diagnosis is very vital for almost all aortic pathologies. We have a lot of endovascular options available, and it can easily be done, safely be done. But centers which can do are very few and limited. But I think that is, in a way, that is good because at least we have started off, we are on par with the rest of the world, and we are doing these procedures with excellent long-term outcomes as well. Thank you.